Mr. Chairman. I know that there is late, but let me say a few words about three rare urgent indications for liver transplantation. If you look at this data from European Liver Transplant Registry, all rare indication to liver transplantation are included in the blue part of the chart. However, it doesn't include specific indication, which I am going to talk about. According to the data mentioned before, we have here secondary biliary cirrhosis, which is often present in bile duct injuries patient, and here accounts for 1.4% of total indication in cirrhosis patient group. So we start from iatrogenic, bile duct injury, and liver transplantation for the bile duct injury is mainly due to secondary biliary cirrhosis and biliovascular destruction. In this excellent multicenter publication, authors present that time interval on the left side of the picture between liver transplantation and bile duct injury was shorter if there had been concomitant vascular injury at the time of cholecystectomy, and the overall survival after liver transplantation equaled 74% at 5 years and about 71% at 10 years. Here a paper new of the French experience published recently, and they presented slightly better long-term survival, but a relatively high percentage of morbidity and mortality. This is our experience in liver transplantation for bile duct injury based on 33 patients transplanted due to secondary biliary cirrhosis and vasculobiliary injury. We achieved quite good results. 1 year survival was 81%, and we achieved an approximate 68 and 58 in survival in 5 and 10 year period respectively. The post-operative complication and mortality are as follows. 8 patients died due to sepsis in 3 cases. 4 patients died due to multi-organ failure, and 1 patient died because of hemorrhagic stroke. Our observation in this group is that they require very challenging operation with often massive bleeding during the transplantation and increased risk of infections and mortality and morbidity. And now the second rare indication, I mean blunt liver trauma patient. Liver transplantation in this group should be considered only in cases where all other therapies have failed in order to achieve hemodynamic stability, or in patients with acute liver failure with necrosis of the liver tissue. These clinical cases occur when there are injuries of the liver grade 4, 5, or 6. Treatment of liver trauma has changed over the past decades, and we can see that about 90% of patients follow a conservative treatment regimen, which include this minimally invasive treatment. And when we have injury grade 1, 2, or 3, so we can treat the patient non-operative with quite good success, but even for grade 4 and 5, unoperable practice can achieve success in about 1/3 of patients. According to this data from European Liver Transplant Registry, published 5 years ago, the indication for liver transplantation, mainly major liver damage with uncontrolled bleeding and acute liver failure, and they achieved a good outcome and 51% after 5 years. And when we look at the literature, we can found that about 72% of patients with liver injury could be treated in one-stage liver transplantation. But we have as well two-stage procedure, which was introduced in 1987 for exceptional clinical issue when toxic liver syndrome has occurred with multi-organ failure due to necrotic liver. Thereby, urgent hepatectomy should be done as quick as possible with temporary portocaval shunt, and the liver transplantation will be done in the second step. In 4 to 6 grades of liver injury, mortality rates are very high. But we can do in that situation hepatic autotransplantation, which was described in 2006 by Boggi. But the patient didn't survive. And here we have a new publication from Philadelphia, which is considered 2 cases treated in the same way and with a good result. I found in European Liver Transplant Registry that because of liver injury was done 73 auto-transplantation. This is our experience in this group of patients of 209 patients treated in the period of 20 years. Only 7 patients were listed for liver transplantation. Procedure were done in 5 patients, but 2 patients died before transplantation because lack of organs. After transplantation, 1 patient died due to multi-organ failure or because of cholangiosepsis. And go to the third rare indication. There is a mushroom poisoning patient. These are common reasons for hospital admission in Europe, but I can find reports from USA and Asia. In Poland, we have 1,400 species, which 200 are unedible and toxic. Main reason for hospitalization is Amatoxin Syndrome caused by Amanita phalloides. But in effect, we have 4 mushrooms which consist alpha, beta, gamma, and epsilon amanitins toxin. The last one, Gyromitra, it has another kind of toxin, but it is as well toxic mushroom. Amatoxin syndrome is mediated by 2 different toxins, namely amatoxin and phallotoxin. Clinically, this is a huge problem, and the patients divided 4 consecutive phases, from ingestion to liver, kidney, enterocytes, damage, brain, edema, and acute liver failure. They are oligopeptides, but these are 9 toxins which are selective inhibitors of RNA polymerase, the second and the third, which are critical enzymes required for production of special peptide in the liver, and synthesis messenger RNA and microRNA. So after intoxication, the protein synthesis stop in the liver, and this is the origin of acute liver failure. Mortality is quite high when we have untreated patient, and when we have treated patient, we can see even a high mortality in adults than in children than in adults. The management of amatoxin poisoning remains a clinical challenge. We can apply many therapeutic options of prevention of toxin absorption, elimination of toxins, and potential antidote treatment, but finally, very often we have to do liver transplantation. The most widely used are the King's College criteria for non-paracetamol acute liver failure when patients are referred for liver transplantation. But as well, there are CHICHE criteria, Ganser's criteria, and the Scudis criteria, and there is no consensus which one are superior. In our department, 90 patients have been transplanted due to amatoxin poisoning. Of them, 8 were treated by fractionated plasma separation and absorption method before liver transplantation. Almost all need continuous renal replacement therapy. More than 31% of patients died in the early period after transplant because of sepsis, multi-organ failure, and brain edema. 5-year survival rate was 54%. Our experience was published a few years ago when we analyzed outcomes in patients with acute amatoxin and paracetamol-induced liver failure. Go to conclusion. About 10% of all liver transplants are due to acute liver failure. Liver transplantation is the last and only option for severe bile duct injury. The time interval between bile duct injury and liver transplantation is shorter when we have concomitant vascular injury at the time of cholecystectomy, because conservative treatment now is very efficiency. Only 10 to 14% of patients with blunt liver injury required surgical intervention, inclusive liver transplantation. We can do this procedure as 1 or 2 stage, as well as hepatic autotransplantation for special cases when we have avulsion trauma. Standard treatment and the liver and kidney support might be quite good in toxin patients, and from time to time we can avoid the need for liver transplantation in this patient. But there are no precise unified criteria for liver transplantation due to amatoxin poisoning patient, and I think we should solve this problem. Thank you very much indeed.
Thank you very much for your lecture. Do we have any questions from the floor? Any? Okay, I'm surprised that we have so many deadly mushrooms in Poland. 200 is very much. Okay, thank you very much. We are closing our session.